which is an HMA meeting, an HMA Academy. So it will be a dual Hungarian and American meeting. So I would like to hand over the microphone to Ákos Koller, President of the Hungarian chapter of HMA, to give a short introduction. And then I think after Ákos, we start. Thank you very much.
Don't hear anything.
Okay, can you hear me now?
I can hear you now.
Yes,
Okay,
yes,
so,
yes.
So then let me repeat myself. Just good morning, America, and good afternoon, Budapest. And we start a lecture series organized together with the Hungarian Medical Association of America and its Hungarian chapter. And the purpose of this to fill out the gap of the physically impossible meetings and try to convey and spread the knowledge among us and around the world. And we start with the neurology. And we are very glad that Professor Meckler and then Professor Frečka will talk about the mind and gut possible connections. And we hope that this series will go on and more people will join us. And now I would like to give the microphone to Professor Chiba.
Thank you. Thank you, colleagues, for the invitation. I hope that everybody hears me. Is it okay?
Yes.
Many years ago, during the COVID time, I have seen a title of the lectures for the lay people. The title of the lecture was The Function of the Brain, shortly. I remember on this title during before that presentation, because the headache is also a very huge topic. We all know that different types of primary and secondary headache exist, migraine, tension type, trigeminal, etc. But one of the most common medical complaints. So dealing with the headaches is an enormous task, but to have some light in the tunnel, it's always welcome. Therefore, I personally, as neurologist, and I'm speaking from Debrecen, and the head president of the Hungarian Neurological Society, welcome any efforts to widen our knowledge about about this jungle, especially because we have no direct information from the United States, from the practice of Professor Meckler, and also from our side, my old friend, Professor Frečka, will present his interesting lectures on this topic. So I would suggest to you, dear colleagues and audience, to have your questions in written form in order to make the presentations fluent. In order to spare time, I should like to ask first Laszlo Meckler. Do you hear me, Laszlo? To start the lecture, I don't know if you hear me, but I see your first slides. The role of Cgrps in the treatment of migraine. Migraine frequency in Hungary is about 8 to 12%. That's for the estimation of the population. So it's very hot topic and important topic. Laszlo, go ahead.
Thank you, Dr. Chiba. It's really an honor and a pleasure to be part of this lecture series. This is something that with Dr. Schwab and we felt this is a way to bring international professors and Hungarian professors together in a lecture series over a period of a year, every other week, supporting the mission and the vision of the Minds Center. Let me just go forward. I hope everything works well. Let me see. Okay, just a moment. Okay. All right, so the Mind Clinic is in Budapest in the Millennium Park. It is a beautiful, beautiful setting. This is a little bit background. We have a center of excellence that will be seeing only outpatient. Stop my video. Outpatient center for neurological and gastrointestinal issues and its effect on the nervous system. As you can tell from these slides, that this is really a state-of-the-art, aesthetically pleasing center that has developed with a soft opening a few weeks ago. What I will just a moment. This doesn't go backwards. Just a moment. Hold on. With just some technical problems here. Okay, apologize, but this is not working for me. Just a moment. Okay. Do you see my slide? Hello?
Your screen. You see your screen.
Okay.
Not the slide, but the screen.
You see the screen. That's it, huh? Yeah, I figured we're going to have problems here.
But some seconds ago, we saw the slides. And now we see your building.
You see the building?
Yes, it is.
Okay, so I'm going to do it this way because the other way. Okay. So do you see my 3 buildings there?
Yes.
I apologize. I'm not sure why it's not working. So the Dendrologic Institute is in Buffalo, New York. We're the largest neuroscience center in the United States. And when Schwab came out, he felt that we can build something in Budapest similar in quality and similar in structure. We see about 1,200 patients every day in the field of neurology. This mind-dent relationship, supported by the Hungarian Medical Association of America, lecture series will be bi-weekly on Fridays at 8 a.m., which is Eastern Standard Time, and 2 p.m. in Hungary. And then hopefully we'll have CME and CEU pending, so physicians can receive credit for these lecture series. And the lecture series will be passed on. So anybody interested, please do send me your email and we'll have you on our list. Let me just talk a little bit. This is information that most neurologists are quite familiar with, but in the context of not knowing exactly the audience, I'm just saying that migraine is a chronic disease with episodic pain, and it has 4 main phases, as you can see in front of you: the prodrome, aura, headache phase, postdrome. The headache phase is 4 to 72 hours. This is the classic International Headache Society classification of migraines. And unfortunately, this disorder is so common that it is actually more common than asthma, type 1 diabetes, and epilepsy put together. In America, it's really closer to 35 million people have migraines, and the prevalence rate is about 12%. The World Health Organization stated that this is the most common neurological disorder and is the second most disabling disorder known to man after chronic low back pain. So if you presume that the prevalence rate for migraine is 12% worldwide, a recent article has showed it to be 14% in Hungary, which means that in Hungary you have 1.2 million people, and just in Budapest you have 250,000 people who have migraines. What's interesting is that when we do research, and I've done research in headache for many years, and we'll be talking about the CGRPs, which we've done research with every company, and fortunately have been FDA approved in the United States. But the strict criteria for migraine is on your left, which basically says that migraines last 4 to 72 hours, normal examination, and has to have 2 of the following: unilateral pulsating, moderate to severe, aggravated by routine physical activity, and at least 1 of the following: nausea or vomiting, photophobia or phonophobia. Now, that is a International Headache Society classification. When we place patients on research studies, the one on the left is what we use. The one on the right is a user-friendly, at-home evaluation of migraine. Basically, what this says, the 3 questions you have to ask: has the headache caused any form of disability? Number 1. Number 2, is there nauseousness? Feel like you can't eat? And number 3, is there photophobia? Now, this is called the id migraine. Let me see. Okay, maybe this. What slide do you see? The full slide, or you can tell me? Okay.
This is the 12th.
Okay. So the id migraine is a Lipton, who's a colleague of mine in New York City, well-known epidemiologist, published in 2003 something to ID migraine, which is at bedside, user-friendly. And the 3 questions, as you noted, is disability, nauseousness, and also photophobia. Now, if 2 of those in the context of a normal examination, and if 2 of those are positive, there's a 93% chance that you have a migraine. If all 3 are positive, you have a 98% chance of migraine. Obviously, your neurologic examination is normal. Now, this has also been supported by Hungarian research, and I'm pleased to see Dr. Badetsky Daniel is on the author list, published in 2018, because it was a validation of the Hungarian version of id migraine questionnaire. And again, this was published out of Hungary. And while I'm here, I would encourage my colleagues who are interested in headache medicine to join the Magyar Fejfájás Társaság. And the problem with the treatment of migraines is that about 60% of patients still are not unhappy with the acute treatment. So many of them have moderate to severe disability still, even if the 1990s when the triptans came out. About 60% are dissatisfied with treatment, and about 10% still overuse opioids and barbiturates such as butalbital, and 8.7% of patients still go to emergency rooms, despite the fact that we've had 20 years of triptans. And it's important for us to understand, this is from the Cameo study of 11,930 patients who were interviewed who had migraines. So even though we think we're doing a great job, even though we have triptans since 1992, and we have preventative drugs from topiramate, valproic acid, beta blockers, we're still having issues. So what is a CGRP? Let's get there. So CGRP, but before we do that, monoclonal antibodies in the clinical practice in the United States, presently we have 90 drugs approved by the FDA. 10% of all new drugs are monoclonal antibodies. And in the field of medicine, 50% are being used in immune system disorders, 31% oncology, and about 3% in neurology. And I promise you that will be changing. So calcitonin gene-related peptide is a 37 amino acid neuropeptide derived from calc gene that encodes calcitonin. It belongs to the calcitonin family that also includes adrenomedullin, calcitonin, and amylin. It has 2 types, alpha and beta. We don't know that much about beta, but we know a fair amount about alpha, which affects the peripheral and central nervous system. That's the predominant form we'll be talking about, alpha. What does CGRP do? Release of CGRP is increased during acute migraine. In 1991, a friend of mine, Goatsby and Edvinson, published the first article about what happens with CGRP during a migraine. It was a very easy study. They looked at the jugular vein. In the midst of migraine, they looked at what kind of neurotransmitters or neuropeptides they found, and they noticed that CGRP was increased. Expressed in the somatosensory autonomic nerves of the nervous system, as well as the gastrointestinal system. CGRP is extremely potent vasodilator, maybe the most potent vasodilator, and CGRP receptors are expressed in the meningeal and mesenteric vasculature. Primary afferent trigeminal fibers express CGRP, especially in the trigeminal vascula, in the trigeminal ganglion within Meckel's cave. Plays a key role in development of central sensitization, peripheral sensitization, and neurogenic inflammation. So here we have two types of neuroreceptors, the inotropic, which is ligand gate transmembrane ion channels. Ligands are neurotransmitters. And what happens here, this is a classic inotropic receptor, but a metabotropic, which is what we're talking about, a G protein or secondary messengers. What happens here is that the CGRP initiates a reaction, which in turn increases intracellular calcium and increases extracellular potassium. So the CGRP complex is a little bit complex. It's made up of a calcitonin-like receptor. It also has a RAMP, which is receptor activated modified protein, and an RCP, which is receptor component. It's a complex G protein, and what happens is by the alpha calcitonin gene peptide, neuropeptides, causes a reaction which increases adenyl cyclase, which increases CMP, and then subsequently the changes that are needed, so-called secondary messengers. So the pathophysiology, let me just go through the pathophysiology quite fast. It's extremely interesting. The first is there's something called cortical spreading of depression. And really that was described by a Brazilian physiologist called Leo, and it's triggered by neurons prone to hyperexcitability. So trigger factors, which is stress, weather, perfumes, alcohol, and so on, can trigger a wave of neuronal hyperexcitability, which is called oligemia. And this causes activation of the trigeminal nociceptors, innervating the dura, release vasoactive neuropeptides, and send pain signals to the trigeminal nucleus, which in turn signals from the trigeminal nucleus backwards to the thalamus, to the sensory cortex, and the perception of pain. So this is the cascade of changes that occur in a migraine. And this is different than Wolf's theory of vascular migraine. It's more like the Moscovich theory of migraine, which is a neurovascular theory. Now, the potential roles of CGRP, it could be that it's involved in the early stages of CSD. One of the peptides involved in neurogenic inflammation and the activation of pain receptors, besides substance P, bradykinin, stimulates further cytokine release and trigeminal neurons to initiate. So there's a whole potential role of CGRP in the migraine. Now, CGRP migraine, how did Goatsby, who's originally from Sydney, Australia, born about half a kilometer where I was born, states that when he checked the jugular vein, there was an increased CGRP content during a migraine. Levels in blood and saliva was also increased. Serum levels elevated intra-ically in chronic migraine, and an infusion of CGRP in migraine-prone patients provoked a migraine. So monoclonal antibodies targeting CGRP or the receptor. So right now in the United States and in Europe, there's actually, these are the approved drugs. The only one that has not improved in Europe was the Alder's drug, which is a drug that is now with Lundbeck from Denmark. It's called eptinizumab. Amgen now, who works with Novartis in marketing erinumab, was the first CGRP that was approved in 2018. Fremanizumab, which is a Jovi, which was marketed and developed by Teva, and then Eli Lilly has Emgality, galcanezumab. So all of them are ligand-specific antagonists, except for Aimovig, which is erinumab. All of them are humanized IG1 or IG2. That's important because the incidence of autoimmune or immunological reactions are very uncommon. The half-lives are quite long because this is a large molecular weight substance, monoclonal antibody, that does not penetrate the blood-brain barrier. The half-lives are quite long. Administration, all of them are sub-Q except eptinizumab, which is called now Vyepti, and the dosages are there underneath. So this is just a review what has been approved in the United States. These are the 4 monoclonal antibodies. So in episodic migraine, these were a summation of the study results. Now, multiple types of migraines were studied. Episodic, defined by less than 15 headaches. Chronic migraine, the definition of chronic migraine is a headache that occurs more than 15 times a month, of which 8 have to have migrainous features lasting more than 4 hours a day. That's the definition of chronic migraine. And just so you understand, the people who don't treat headaches, chronic migraine is probably one of the most disabling disorders known to mankind, and it's a very difficult type of headache to treat. So in these studies, this is a summary slide, the reduction of the mean migraine monthly days, meaning if you had 20 headaches a month, what happens in the reduction? So these are by days. So you see a reduction of 4.3 to 4.5, depending on how many days. Now, then you ask the question, if you have 15 headaches a month, what percent of patients had more than a 50% reduction in monthly migraine days? And that number is 56% for eptinizumab, 43 to 50% for erinumab, and as you can see, 61% for galcanezumab or Emgality. Then you ask the question, how about a 75% reduction? Now, let's step back. These are disabling headaches by definition. These are not mild headaches. These are migrainous headaches, and by definition, disabling. So to get a 75% reduction with eptinizumab, you got a 40% of patients who had 75 and 100%, meaning no more headaches. 20% of patients had 100% reduction. These numbers are very encouraging. And you can see, this is something that I have published, is that what percent of patients who had prior treatment failures had 50% reduction, close to 50%. For, well, Emgality was 56%, Aimovig was 40%. So here's some numbers. I'm not going to go into the exact, I don't have time to show you exactly. That was for episodic migraine. Here's chronic migraine. Let me show you that a 50% reduction, 61% of patients reached that with Lumbeck study, Alder, with eptinizumab, which is now called Vyepti. That's an IV every 3 months. So if you have somebody who has over 15 headaches a month, disabling headaches, they have a 61% reduction, and relatively fast in the first month after the first IV. Really remarkable numbers. 75% reduction is 33% and 100%. Imagine having 20 headaches a month or 30 headaches a month for 10 years, and then you get 100% reduction, even if it's 15%. Remarkable numbers. All right. So this is just a taste of how we did the study. Here's 2 studies in front of you with eptinizumab, episodic, then chronic. In the episodic, you had a screening and a randomization. 1/3 got placebo, 1/3 got 100 milligrams, and 1/3 got 300. And by definition, you needed to have 4 to 14 headaches a month. On the other side, you see the chronic migraine, which is called PROMISE 2. Again, screening, randomization to the 3 arms, placebo, Vyepti, 100 and 300, about 360 patients in each arm. And this is just some of the results we have. In episodic migraine on the left, chronic migraine on the right, what percent of patients got more than a 75% reduction of headache days? And you see those numbers, 31% on both sides after the first dose. And this is an IV every 3 months. And percent of patients who have 100% responder. In episodic migraine, 20% of headaches went away completely. In general, about 50% got 50% better. And in chronic migraine, 17.8% after 2 dosages had complete resolution of their headaches in chronic migraine. Now, I will tell you, in open label extension studies, these numbers are even better. So at 1 year, we see even better numbers than what you see here. So small molecule. So I talked about monoclonal antibodies and CGRPs. Let me talk to you a little bit about antagonists. These are small molecule receptor antagonists. These are not monoclonal antibodies. These are small. And right now in the United States, we have two. Japan, which is a Ubrelvy, and Japan, which is called Nurtec. Japan is what we're doing research with right now for prevention. It's an oral medication, and it's very interesting. Many years ago, I did research with Merck, but unfortunately, when we were looking at CGRP receptor antagonists, we had hepatotoxicity. So the Merck basically pulled out of the research, but still, they found other drugs without the hepatotoxicity that we saw initially. So what's the difference between a GPAN, which is small molecular, and a monoclonal antibody? You can see the kilodalton. It's much bigger, so it doesn't, monoclonals do not penetrate the blood-brain barrier. GPANs are for acute. Monoclonals are preventative. GPANs work within minutes and hours. Monoclonals 3 to 6 weeks, although you see benefit at about 48 hours. Target, monoclonals are highly specific, affinity. GPANs are low. The clearance is through the liver and kidney. And monoclonal is interesting. It's with the reticular endothelial system. Administration, parenteral, oral, blood-brain barrier, we talked about. Immunogenicity, we do see it with monoclonals. It's very low. What's interesting is that these monoclonal antibodies and the GPANs, CGRP, the GPANs are actually vying for position with the triptans. The beauty about the GPANs is that we've not seen any cardiovascular issues. So anybody over the age of 55, 60, in smokers, in people with heart disease, cerebral vascular disease, peripheral vascular disease, GPANs are probably the drug of choice over triptans. So these are the CGRP antagonist binding sites. As you can see, this is Ariminab, which is Aimovig. That's a CGRP receptor. The other ones are ligand. So the fremanezumab, galcanezumab, eptinezumab are to the ligand. And then obviously, when we talk about antagonists, such as Ubrelvy and GPANs, they go also to the receptor. All right, so that's a little, so the thing is, everybody's gonna say in Hungary and the United States, well, this costs too much. Well, the problem is, yes, it costs too much, but let's look at studies with Steve Silberstein. Steve Silberstein noted that when you put somebody on preventative medication, at the end of the day, it reduces medical economic cost over an 18-month period. 51% less office visits, 88% less MRI scans, 75% less CT scans. ED is ambulancia, so emergency room visits are down. So when you treat somebody aggressively for episodic frequent migraines and chronic migraines, this is what you have. And to support that, this is a study that I've just published, is the estimated impact on direct medical costs associated with eptinezumab treatment for migraines. So I don't want to go through the slide. All I say that there's significant cost-benefit ratio in patients who are aggressively treated with CGRP monoclonals. Another study I looked at is the
impact of fremanezumab on migraine-associated symptoms in patients with episodic.
That's me. All right. So Nurtec is Rimegepant. It was approved in February 2020 in the United States. It's marketed by Biohaven. We give 75 milligrams. I just wanted to show you these two. Ubrelvy is a CGRP receptor developed for acute treatment of migraine, approved in December 29, 2019, marketed by Allergan. I'm not going to go through the studies. And Atogepant is something we're studying right now, looking at it in different disorders, including medication overuse headaches. So how are they different from now? How would they change the paradigm? So these CGRPs, how they are different from now? Well, they're fast. They actually work in the first week. Either you give it sub-Q or intravenously, you see benefit in the first week. And this is something I cannot overemphasize. in the past, when I gave topiramate, I had to go 5-10 minutes of talking about potential side effects, or valproic acid, or even beta blockers, or even amitriptyline, which are tricyclics. Tolerability of these drugs are remarkable. In fact, the first drug that came out, Aimovig, had about a 3% incidence of constipation compared to placebo, which is 1%. Except if you're allergic to it, really, we don't see any major cardiac, renal, hepatic, gastrointestinal side effect. Even the constipation resolved in open label extension studies. So the safety and effectiveness is truly remarkable. We don't use it in pregnancy. We don't use it in patients with lactation, only because we do not have enough information. But otherwise, these are extremely safe with subtle, if any, side effects. What we don't know is the long-term safety, although there's been over 323,000 patients treated with Aimovig, and we have not seen any long-term side effects. The only thing we have seen is a few patients had hypertension while they were receiving it, so we do monitor for new onset of high blood pressure. The cost and access is an issue. But some of the medical economic studies that we are doing showing the benefit in the long run. So the impact of challenging evidence suggests that Cgrp is a neuropeptide intimately involved in the pathophysiology of migraine. The modulation of Cgrp through GPANs and monoclonal antibodies has proven to be effective in the acute and preventive treatment of migraines. This is the first monoclonal antibody novel specific migraine preventive. Everything else preventative, even Botox, was done by, let's be honest, accident. Depakote and Topamax are anticonvulsants. Tricyclics were antidepressants. So they're coming soon. You have to be prepared for them because the population wants it in America. I don't have a patient coming in here who does not know about these drugs, who are very eager because maybe they're on a drug right now, such as topiramate. Ask them if they're happy with it. Ask them if they have memory issues, word finding issues, tingling, and so on. So they're coming soon. Now, after my talk, I hope I gave the person enough time. I think I did. We're going to be talking about lifestyle and gastrointestinal and nutrition. Nutrition obviously is very important. We just talked about a half an hour about medications, but I will tell you that lifestyle changes. And I think we can talk about my Hungarian dog here, who as you can tell, is a heavy drinker and smoker and a little bit overweight, is not uncommon in Hungary. So we are very important in nutrition. All my patients I talk to about their diet, and there are specific diets that are very, very helpful in migraines. And I'm sure that this will be discussed in the next few minutes. And before I leave, I'm very happy to be the first lecturer in this series. I would encourage my colleagues in Hungary and the United States to send me a lecture that we can present in the future. I think this is a format that will embrace the knowledge in Europe and in the United States and improve our collegial relationships. And I thank the Hungarian Medical Association to give me the opportunity to be part of the exchange program and also be a part of a worldwide network of extremely talented Hungarian physicians practicing in different parts of the world. I especially want to thank one person, Shab Ritchie, who without him, we could not be here today. He is an extremely talented physician and an individual who builds things. And with him, I think we're going to build a center of excellence in Hungary to be enjoyed by the Hungarian population and my colleagues, working together in network to build something very special for education, for research, and for clinical practice. Thank you very much. So we have a chat room. If Dr. Chiba, if there's any questions, please be free.
Thank you very much, Laszlo, for the excellent presentation. And as you mentioned, Laszlo is waiting for the questions by chat. and at the end of the second lecture or after the second lecture, you can answer the questions if you wish in written form, or if you have some time, then you can tell us for everybody. I have only one single remark. These new drugs are not just in the progress by registration, some of them in Hungary, and the problem will be in the future the following: the costs. You also, in one of your last slides, you mentioned the problem of the cost. I'm sure that those people who will be reimbursed by the Hungarian insurance system should be screened or filtered by the new system, because the cost will be probably very high. And similarly to the MS therapy and other therapy, we have to prove the non-efficacy of the previous treatment. And I don't know exactly the criteria. If such a criteria exists in states before to start with this therapy, please tell me, Laszlo. And the second, the screening, if this is a migraine or non-migraine, is very important. Is it possible to get electronically or in written form, it doesn't matter, your screening form if a newborn patient arrives to your department, to your clinic, before to start the therapy? What is, because it's always very useful for another center to see the screening questionnaire and others, not only these simple three questions, but others, in order to find the appropriate patient for the appropriate therapy. So, summarizing, is it possible to get your questionnaire electronically, perhaps for everybody, but for me, yes. Second, could you answer the problem of screening for and the cost, about, if you can tell us something?
So the expense of these drugs are quite high, anywhere between 5,000 and 8,000 American dollars per year for these injections, about $560 per injection. Some are monthly, some are 3 months. So in the United States, the FDA has approved it. The insurance companies are paying for it, but you have to either fail 2 maintenance drugs, such as topiramate or amitriptyline, and in some drug companies say that you have to fail Botox, which in itself is not cheap for chronic migraines. You know, in Hungary, it's going to be a difficult issue. I know for a fact that Aimovig, which is made by Novartis, is essentially only 3 patients in the country are using it. And this is after a discussion I had 2 weeks ago. And it's obviously self-pay. So I think one thing I've recommended is that we start doing research on Hungarian patients and look at the benefit ratio, meaning medical economically, is there a benefit? We know there's a benefit in quality of life, unequivocally. Now there's, you know, as you all know, in headache medicine, we have something called absenteeism and presenteeism. So if I have 500 people working for me here at my institute, and when a nurse doesn't come in because of migraine, that's called absenteeism. Or if a nurse comes to work but is unable to function, that's called presenteeism. So there is a reason to be aggressively treating these patients who are in chronic pain. But you're right, the cost benefit has to be looked at. And my recommendation is, first of all, treat the worst of the worst, which is the chronic migraine patient. Treat that aggressively. And consider using CGRPs for at least that population initially. And then we'll see what happens with the episodic migraines or the frequent episodic migraines. So, but you know, the problem is it's going to be out there. It's going to be the future. And because A, it's safe. B, there's no interaction with other drugs, such as blood thinners or heart medications. And when the triptans came out, when Imitrex first came out in 1992, I remember because I was part of that research team, triptans was so expensive that they said that nobody could afford it. But they can, and they have, and then we have generics. So it's going to take time, but I think the monoclonal antibody are here to stay because of its safety record and because of its efficacy record. So I'll leave it at that. And I would like to leave 20 minutes for my colleague to talk about the nutritional aspects in regard to headaches. Thank you very much.
Thank you, Laszlo. We wanted to chat with him and to send the questions to Laszlo, but now we have to jump to the other second presentation given by my friend Ede Frečka, who came back to our country some years ago, but lived also in the United States for many years. Ede, please.
Okay, thank you. Please let me share my slides. I cannot share it until other participant is sharing.
At present, I see the slide of
Laci, can you unshare your screen?
Okay, all right. Yes, thank you very much.
Share you.
Okay. So thank you very much having me in. I'm happy to be the second one. And about myself, that I used to participate on the Sarasota meeting of HMAA 20 years ago. So hi to everyone, and extra hi to those who remember me. The language of my presentation is Hunglish. My slides are written in Hungarian, and I will interpret them in a language which sounds like English.
Excuse me for the interruption, Ede, but is it possible to ask everybody to unmute?
Yes. I feel echoes, so I request everyone.
Everybody should unmute or mute. Sorry.
The inviter can unmute every participant in Zoom. Yes, because there is an echo. So I like to make my point at the very beginning of my presentation, just in case some people would fall asleep. So one of the important points I would like to make, if it is true that chronic low-grade inflammation is in the background of almost every diseases of civilization, then the gut flora is definitely involved because of the strong interaction between the gut bacteria and the immune system. Gut bacteria can make any inflammation better or worse. The other important that gut bacteria, they are very sensitive to lifestyle changes, especially diet, but other lifestyle changes, for example, being outdoors or doing physical exercise, they all can quickly change the composition of the gut flora. I will also include some slides showing how the gut flora can influence headaches. So right now I jumped to this basic sentence which goes back to Hippocrates, that every illness starts in the gut. But it was not only him, he had followers. Ilya Mechnikov, the founder of immunology, and Philip Pinel said the same about neuropsychiatric disorders, and he's considered one of the founding fathers of modern psychiatry. But from the gut to the brain, the road is very capricious, very long. I try to boil down on two stages. One is dysbiotic gut flora, when the balance, composition of the gut flora is changed. Some species phyla outgrow the others. That can come with increased permeability of the gut, and it can result in chronic low-grade inflammation, which results in microglia activation in the brain. Microglia is the resident macrophage within the brain. I think it's important to understand that the gut is the largest surface, the gut wall is the largest surface between us and the environment, and it is composited only by one cellular layer. I think it's a serious vulnerability. It's a huge amount of bacterium on the other side. And indeed, if anything changes, the attachment of gut mucosa cells, that can cause increased permeability and it can result in several problems, intolerance of diet, autoimmune problems, and chronic low-grade inflammation. My colleagues know me very well about my provocative questions. First provocative questions: which are the two dumbest species on Earth among those million species what we have here? From my point, definitely those who are not clear about their basic necessities. And you see at the base of the Maslow pyramid of need, it is food. And I hope you agree with me, if there are dozens of dietary advices out there, that is not sign of the knowledge. I think that's sign of something else, but not knowledge. So apparently Homo sapiens is not on the top if it is not clear about its basic.
A mikrofonhoz.
Igen, közel vagyok.
Rossz a hangkapcsolat.
Okay. The other species is the best friend, the dog. Domestication, we started 8,000 before Christ, made a lot of anthropological, anatomical, and health changes. Some of them were not for the better. So nutrition deficiencies cropped up, infectious disease due to the settlement and increased population. There was a decrease in height. Very few people know that only the Dutch population reached the height of the Cro-Magnon man, and even less people know that over the last 20,000 years, our brain has been shrinking. Some groups suppose that it is something good. There is a debate. The other says that it's not a good sign. I put my vote on the latter, especially because for me it's fishy that a shrinking brain is telling about itself that shrinking is not bad. While in anthropology, the last 2 million years was always about every cubic centimeter increase in the brain, and suddenly when the trend changes, some interpretations, they says it's not good. Genetics shows that over the last 10,000 years, we have been losing important intelligence and emotional stability genes. And the question, what is behind this? Definitely not behind the genetical changes, but behind those health changes I mentioned before, lifestyle changes, sedentary lifestyle, and the huge change by the agricultural diet, definitely a factor in it. Dietary recommendations, they usually focus on what kind of calorie source we should use, what kind of essential components we need, and some aspects are raised about bioregulatory, phytochemicals, antioxidants, anti-inflammatory, flavonoids, steroids, but less focus about puberty, because according to anthropologists, entering meat into our food and delaying puberty was an important push for increased brain size. And the trend that puberty happens earlier, some people suppose it's the result of good diet. Again, I am in that camp which says, no, this is not in the good result of the good diet, but some poor diet, because it is anti-evolutionary. Sexual steroids slow down the development of the brain. Maturation can be delayed by early puberty. And there is a fifth aspect of what you can figure it out, but I will emphasize it at the end. The dietary recommendations much focus more and more on the health of the gut flora, especially the diversity. Diversity is the key if we approach the gut flora, if we approach the ecosystem, but even finances, you know, diverse your investment. That's an important advice. So diversity is a key. So what is you and more than you? Oh, yes, it is the microbiota. You know that we have more cells in our gut than human cells, and the genome of the gut flora is enormous. The number has been increasing by the improvement of gene sequencing, because gene sequencing made the breakthrough understanding the gut flora. So we have more than 40,000 different species in the gut. And if the gut flora is like an ecosystem, we cannot approach the ecosystem pinpointing some species as desirable, other species as undesirable. It's more complex. Normal gut flora is variable, but it shows some stability. Especially the variability can be results of the diet. And changing diet within days, we can change the gut flora, but at the same time, going outdoors, doing gardening, you can find that 2 days later, 30, 40 bacteria species show up in the gut, which came from the garden. So the gut flora is very important in fermenting extra calories. Lucky guys who have a gut flora which burn down 25% of the calorie intake, they will not get as much fat. Very important that they train the immune system, especially during the first 6 months of the life. I have no time to discuss what's happening to cesarean section babies, what is the problem with them. And what is important that slow chain fatty acids, it provides for the brain, vitamins, and it's very interesting that some chemotherapeutic agents, they essentially work through the gut flora, forcing the gut flora to build a Th17 anti-tumor environment. You heard about the gut-brain axis. My group prefers the big T brain immune gut triangle because it's an even-sided háromszög triangle. Each interaction on each side is very important, and the gut flora influences those interactions. The gut flora can influence through the vagus nerve and through the bloodstream gene expression in the brain, and especially the emotional centers of the brain. The vagus nerve is a main road for communication. We have learned lately that alpha-synuclein mostly goes up to the brain through the vagus nerve, and it gets deposited in Lewy bodies. Stress reaction, highly influenced by gut. Anxious rats can be brave if feces of brave rats transplanted into them, and vice versa. And the same has been done for depression. So transplanting the feces can change the behavior. So there are many, many factors which influence the function of the gut. I already emphasized the diet and the environment. I just referred briefly to the way of delivery, but physical exercise, several drugs, it can influence the gut flora. Dysbiosis, when the gut flora is in disbalance, this can lead to increased permeability of the gut, and several diseases, more and more diseases, are in connection with the leaky gut, so-called. Here I just emphasize antibiotics, non-steroidal proton pump inhibitors, and phosphodiesterase inhibitors. They can influence the permeability of the gut. This is another reason why we have to be careful, using antibiotics, just really good clinical indication. It is not only the antibiotic resistance, but second to it, any antibiotics, not only the broad spectrum, they represent a nuclear attack on the gut flora, and gut flora needs longer and long time to recover after each antibiotic treatment. The leaky gut comes with several symptoms, headache is included, and more and more illnesses, they get read on this slide, which has some relationship to the gut flora and leaky gut, and migraine is also there. You can find the recent publication, what the gut can teach us about migraine and how one can influence migraine headaches by probiotics And the mechanism, from the gut through headaches, it goes through the pro-inflammatory immune proteins, which cause central sensitization, increasing pain. And the microglia is an important protagonist of this process, because microglia, the resident macrophage in the central nervous system, it can seed, it can prune, and it can weed out unnecessary components. One can call the microglia as the gardener of the brain. The third provocative question, what is your favorite pet? For me, it is not kitten and puppy. The gut flora is my favorite pet. I try to nurture it every day, because increasing the diversity, I think it's very important for the gut flora. Probiotics are very important if the gut flora got a big hit, if it was wiped out by broad-spectrum antibiotics, but a quasi-normal gut flora probably can make healthier by prebiotics, which can increase the diversity much more. So what are the ways, to support the gut flora? So very, very diverse fibers from plants, adequate sleep, exercise, and minimizing simple carbohydrate, alcohol, antibiotics, and including in the diet prebiotics, pectin, inulin. Korea, for example, has inulin, pectin in apple skin, and many plant fibers are good prebiotics, and they can nurture dozens of gut bacteria, not only one or two. Among fermented food, kimchi, sauerkraut are great. And discussing diet, what can be the possible optimal diet? My point is the optimal diet is the old one. The oldest one, what tropical hunter-gatherers have, which is very similar to primate or monkey diet. The essence of their diet, extreme diversity. They eat at least 80 different plants a day. It's little for many. It's impossible for us to do this. And they pick from 500, 600 plants per year. At the West, even the most affluent family can pick from 50 plant sources per year. So this optimal diet, what I suppose it's impossible to reach for us. So diversity is the key, and the rotation. They don't eat the same food all year long. They don't have staple food. Mexico has staple food, corn. Ireland has staple food, potato. In Hungary, we have staple food, wheat and potato products. And we eat a lot of this instead of picking like Mediterranean diet, which incorporates a higher diversity of plant sources in diet. This is just a way how to emulate the primate diet, which is really a mixture of fruits and leaves, just a little from many. It depends on everyone's taste buds. Sometimes the taste is horrible, but definitely with this mixture, one can get 15 or 20 plant sources a day. This is just a study showing how some very useful gut bacteria, Akkermansia, for example, Akkermansia, the guy which can decrease the weight because consumes extra calories, it can show up after 3 days of this diet. So, okay, this is my last conclusion. So please support your gut flora, because I'm not saying that it can cure, for example, depression or cure anxiety, but possibly the right diet can help in preventing relapses. That's my point. Probably a good diet and lifestyle has an influence on it. Thank you for your attention.
Hello, Ade.
Yeah.
Sometimes the line was not optimal. I don't know what was the cause, but about 90% was very audible and very well visible.
I'm sorry.
It's probably not your problem or your mistake, but the line was, or the internet connection was unstable. Anyway, if you want to have any comment or question, please either chat or, I don't know, Richie, can we continue with questions or only with written form or chat, or how long can we continue this presentation? As I saw, we are all together 10 on the lines, 10 participants only.
And here we have an additional 10 approximately.
Yeah, you are more, yes. Because here on my screen, I see 10 participants. So
I think the biggest limitation is Lotzi Matchler. So how much time do you have, Lotzi, left?
Laszlo, do you hear us?
Can you hear me?
Yes, we hear.
So normally these lecture series, I've been running these lecture series for about 15 years. Normally it's 1 hour because, you know, I see a Lord on my neurosurgical colleague and friend. So usually it's a 45 minutes talk and then 10-15 minutes discussion. So at the hour we stop, and that's professional, because otherwise you're interfering with other people's you know, work day. So we start at 8, we go to 9 Buffalo time, and we have questions after 45 minutes. That's what I recommend for the future, but we'll have a nice discussion on how to proceed.
Okay. Now go ahead. Some short questions. I myself have 2 questions, but please go ahead. And somebody, perhaps Richie, ask something from you, Laszlo, about...
I wanted to ask you one question, Lotzi. I sent it via the chat as well. Can you comment on possible diagnostics for CGRPs in order to personalize the therapy?
Yeah. So right now we are not doing CGRP levels, you know, prior or during treatment. I think there's a cost issue to that. So we don't correlate results with CGRP levels.
But the reason of the question is, let's say, if you have 50% benefit approximately, you could basically triage the patients before. So patients with high CGRP levels.
Yes.
Possible to enter.
Can't hear you, Richie.
Sorry. So we could enter, for instance, is there a criteria to enter with a cutoff level of high CGRP levels for the inhibitors, so that that might be, because if you have 50% efficacy, maybe you can pre-select even the 15 super responders with super high CGRP levels.
So that we have not seen a correlation between that, but it's an interesting point. It's a study that could be done. In other words, people who respond to monoclonals respond because they had high CGRPs. People who don't respond had low CGRPs. Something that we could look into. I can talk to some of the companies and see if they're interested in do a pharmacokinetic study.
Mm-hmm.
Right now, there's no correlation between CGRP levels and efficacy. I can say that, but I don't think it's been looked at that well.
Yeah.
Okay.
Can I have a question?
Please.
Yes. Can you see that somebody has a migraine on MRI?
So not on regular MRI. There's some thoughts about functional MRI. So, and there's indirect findings of what we call T2 star or SWI changes in the locus coeruleus and the raphe nuclei, but they're indirect and not for acute migraine. So functional MRI, yes. PET scan, yes, but not routine MRI.
Can I have also 2 questions?
Yes, Yes.
So, of course, the new era of anti-migraine therapy is welcome. But before to start this therapy, many patients will start with other old intervention.
Yes.
How is your personal experience with the injection as prevention, for example, the occipital nerve infiltration with steroid and lidocaine, 80 milligram, for example, and 2 milliliter lidocaine? Second question, the triptan. If you have a typical migraine with, for example, 2 to 3 attack lasting 1 day, 30, 40, female, with the vegetative syndromes, quality of life worsened, which triptan would you prefer?
First question was the question about, your first question was what exactly?
Occipital nerve infiltration,
I'm sorry.
prednisone,
So,
steroid, and lidocaine, because there are publications about the efficacy. Or you can also speak about the transcranial magnetic stimulation experience if you wish, or TENS stimulation if you have some remarks.
so we see about 220 patients every day in headache medicine at my institute. Of the 220, about 40 of them are receiving either muscular trigger points or occipital nerve blocks or sphenopalatine blocks. So I do feel strongly there's a subset of patients who respond extremely well to these procedures. So we routinely use it. So every time I see a headache patient, I palpate the muscles in the neck and the trapezius. If there's a lot of tension, especially in chronic headaches, then they do routinely receive trigger points or occipital nerve blocks. I think that's your first question. The second question is which triptan to use. We have 7 triptans here in America, and there's different pharmacokinetics. I still think that the best triptan is sub-Q Imitrex. Unfortunately, many people, maybe 40%, do not tolerate the shot sub-Q. So I do use a lot of oral sumatriptan. Rizatriptan is one of my favorites. Rizatriptan has a melt that you put on your tongue. It has a peppermint taste to it. Young people enjoy rizatriptan. The older you get, then I start using other triptans such as naratriptan and almotriptan. But every triptan is to be utilized, and when one fails, I'll try another one. So I think that's the triptan discussion that you requested. There was a third question there, Dr. Chiba. What was the third question? I think that was, so the triptans.
Magnetic stimulation.
Yes. We do have transmagnetic stimulation here. And we use it mostly for depression because it's indicated. We don't use it for episodic, rarely chronic migraine unless there's a severe depression. I tell you what I do use here for chronic migraines and patients who don't respond to normal care. I use ketamine. So ketamine infusion is being used for the chronic migraine, chronic pain, even chronic depression. So we have an outpatient ketamine clinic here where we do about, I would say, 8 patients a day, 6 to 8 patients a day for ketamine. So I will do that. And obviously I use everything from massage therapy, physical therapy, even chiropractic therapy or Chonkovach. So I will use anything to work on the neck in patients with chronic pain. So we utilize a lot of things, including diet and vitamins and obviously we use a lot of CBD. We use a lot of medical marijuana for patients in chronic migraines. Not episodic, but chronic migraines, we use a lot of medical marijuana. I just published an article a few days ago on chronic migraine and the use of medical marijuana. I'll be happy to forward you that article, Dr. Chiba.
Thank you very much, Laszlo.
Yes.
My name is Laszlo, not Dr. Chiba. Every second man in Hungary is Laszlo.
Yes, and every other one's Istvan.
May I ask?
Yes, Loran.
Go ahead and ask questions from Ada if you have.
Yeah. Hi, Loran Dervish from Budapest, the National Institute of Clinical Neuroscience. Nem tudom, beszéljünk magyarul? Van angol, aki... Az a kérdésem, hogy van-e tapasztalatod a krónikus, vagy akár az epizódikus migrén terápiájában neuromodulációval? Ugye itt említettétek a blokkádokat, hát ez volt a kezdete annak, hogy valamilyen módon modulálva legyen az okcipitális régió, illetve az okcipitális ideg. Ma ugye pont a Goldsbyékkal csináltunk egy nagy studyt, és mind a cluster headache-ben, mind pedig ugye migrénben nagyon szép eredmények jöttek ki. Mit tudtok ti mondani az ottani kinti gyakorlatról? Az USA-ban van-e akár FDA engedély erre, vagy valamilyen praxis kialakult?
Ja, mi is csináltuk azt a neurostimulator, sphenopalatine neurostimulator for the treatment of cluster headaches. És sikerült, és tényleg hatásos. Azt a studyt, azt hiszem publikáltuk 1-2 évvel ezelőtt. A FDA nem nagyon engedi azt, hogy neurostimulation, neuromodulation for migraines. Possibly for occipital neuralgia, trigeminal neuralgia, és cluster fejfájásokra, igen. So all I can say is that insurances don't pay for it, unfortunately, very expensive. But in a subset of population that's not responding, aki nem reagál kezelésre, az a csoport érdemes ezen gondolkozni. Főleg a trigeminal neuralgia, főleg a occipital neuralgia, and definitely a cluster fejfájások, az biztos, hogy hatásos. Láttam a saját betegeimen, hogy ez a stimulátor működik. Gondolom te is, Lorán, láttál pár pozitív esetet.
Igen, implantáltunk, és nagyon jól vannak a klaszteresek.
Nagyon jó vannak, igen, én is így látom. Migrén ez más kérdés, mert tudod, a sphenopalatine ganglion nem annyira fontos a migrénnél, mint a cluster. Clusternál tényleg fontos.
Thank you. Any other question? Valaki más gyerekek, akár Mekler-proftól, akár Frecska-proftól, kérdezetek bátran. Please ask if you... I see that by Richie, people sit and curious about the opinion of Laszlo and Ede.
Igen, egy kérdésem, hogyha lehet.
Hangosan lehet.
Igen, most hallatszik?
Most nagyon jó.
Jó. Tóth Gábor Tamás, gasztroenterológus. Frecska doktortól kérdezném, hogy esetleg lehet-e az, hogy lesz majd célzott probiotikus kezelés bizonyos panaszokra, vagy bizonyos eltérésekre? Mert ugye most a betegek azt kérdezik, ha valakinek hasmenése van, ha valakinek székrekedése van, ha valakinek puffadása van, hogy honnan fogja tudni, hogy milyen típusú probiotikumot szedjen, mert most nagyjából ugye hasonló vagy pár szert használunk, de van erre valamilyen következtetés, hogy akár a panaszok alapján, vagy akár a székletgenomika alapján tudunk választani a probiotikumok közül, vagy a lehetőségek közül?
Igen, tehát vannak próbálkozások bizonyos spíciek, Prevotella, Lactobacillus. Én főképpen a pszichiátriai vonatkozását ismerem, és igen, ezt keresik, de azt kell mondanom, hogy nagyon kell vigyázni, mert már olyan fogalom is van, hogy probiózis. Tehát probiotikummal is lehet diszbiózist csinálni, tehát amikor túlnyomjuk ezt a dolgot. És amint mondtam a legvégén, kétségeim vannak, hogy egy csomó betegségben az akut fázist lehetne ilyen módon kezelni, de valószínűleg a prevencióban lesz ezeknek óriási szerepe. Az én területemen depresszió és szorongás terén nem hiszem, hogy egy akut depressziót bármilyen probiotikummal meg tudnánk fordítani, de lehet, hogy a relapszus rátát ritkítani tudjuk.
Én egy dolgot, may I ask Dr. Frecska, one question, maybe I turn to English, possibly there are participants online who don't speak Hungarian. Can you comment on gluten-free diet? and or histidine, so not rich, but so low levels of histidine in the diet, basically low casein containing diet in terms of migraines. I've seen lots of patients reporting to me good efficacy. I have no evidence for that, but lots of I've heard lots of rumors and anecdotes on the low histidine and or low gluten or gluten-free diet. Lots of patients tell this.
Yeah, as you know, migraine is not my field. So after this invitation, I looked into the literature and studying the gut flora and gut function is really in an early stage. So I don't know about gluten in migraine, but the issue is that since we already developed to a certain degree of leaky gut, many food components which did not cause problem, let's say 100 years ago, they became a problem nowadays, especially gluten. Just there are two factors which increase the gluten problem. Domestication of the wheat, which increase 100 times the gluten. Gluten is not water soluble. How fine is the flour has a big effect, and modern meal industry does a better job, you know, like 100 or 200 years ago. So that's another reason why gluten is coming up as a problem. We can notice that. And the other reason that most of us, we have a certain degree leaky gut, and that kind of food component which did not cause problem in the past, yes, they can be a problem nowadays.
Richie, unfortunately, I have to go. I have a slight emergency, but it was really a pleasure with Lotzi and Eda. I think we will work out some of the technical issues, but I think this is something that I like to present to the Hungarian neurology residents or neurosurgical residents, depending on the topic. But going forward, I think this is a venue that should be utilized by many of our colleagues, because I think going forward, we'll have a list of high-level professors of different forms of neurology and gastroenterology working together to discuss topics that are important in today's medicine. So on my part, I'd like to thank your organization, and then I will move forward and looking forward to the next lecture, and we'll give that announcement when the next lecture is. Thank you.
Thank you very much. Thank you very much.
Thank you very much, Laszlo. Have a nice day. Have a nice week.
Thank you.
Okay, thank you.
Thank you. Bye-bye.
Bye-bye. Thank you.
Hát gyerekek, nem tudom, hogy folytassuk-e még angolul. Szerintem maradjunk, most már összesen vagyunk tokkal vonóval egy nehányan. Van-e még kérdés? Do you have any question? Hát ha nem, akkor ezt a két rendkívül értékes előadást köszönjük szépen. Én egész életemben öreganyámnak szólítanám Frecska Ede barátomat, hogyha az előadásnak a nem, hogy mondják, ezt copyrightos diáit átküldeni.
Átküldöm én ezt gond nélkül. A hosszú verziót, mert gyorsan lerövidítettem. Ja.
És én egy jó kezdeményezésnek tartom, most már az minden kezdet nehéz, de szerintem ez elég jól sikerült. Szerintem egy kicsit nagyobb popularitást lehetne tenni, hogyha fel tudnánk tenni például a Magyar Neurológiai Társaság weblapjára, amin nagyon sokan szoktak látogatni, de nyilván nem az utolsó pillanatban, hanem mondjuk 4-5-6 nappal, egy héttel előtte. Úgyhogy Ricsi, hogyha ilyen a következő lesz, akkor, és ez nem titkos, akkor szívesen feltetetem, miután ehhez van lehetőségem, hogy bárki csatlakozzon az országból vagy a határokon kívülről.
Nagyon szépen köszönjük a kommentet. Hadd mondjam azt, hogy ugye most nyílt az intézet, az az elképzelésünk, hogy megpróbáljuk januárra olyan állapotba hozni az együttműködést az HMAA-vel, a technikai feltételeket, a fórumokat, hogy ezt igazából, megmondom őszintén, az a tervünk, hogy egy januárig ilyen soft opening formában elindítjuk, akkor lesz egy nagyobb lépés, és az igazán nagy lépés az akkreditáció után lenne. És ennek a fóruma nem csak a neurológia társaság lenne, én azt gondolom, ezek olyan témák, ami sokkal szélesebb, házi orvostól kezdve társszakmákat érintő praxisokat is érint, és a Facebooknak köszönhetően, és itt van a körünkben Tóth Ákos, aki a marketing és kommunikációs vezetője a Mind-nak, azt hadd mondjam el, hogy mi ebben úgy szeretnénk részt venni és támogatóan beleállni, hogy ennek a popularitását, idézőjelben téve mondom, nem orvosi, professzionális módszerekkel, Ákos csapatának a segítségével, és a Facebook és az Instagram segítségével egy új szintre próbáljuk majd megemelni. És ebben nagyon köszönöm, hogyha felteszed a társaság honlapjára is, de az az elképzelésünk, hogy ez ezen talán még túlmutatóan is nagyon-nagyon izgalmas lehet. Azt is látjuk, hogy rendkívül sok érdeklődő beteg ma már szeretne közvetlen orvosokat és szakértőket hallani, még hogyha nem is az ő, hogy mondjam, nem betegeknek, és nem így szánjuk ezeket az előadásokat, de azt gondolom, hogy az orvostól, a hallgatóktól a házi orvosokig ez egy nagyon széles hogy mondjam, audienciára igyekszik majd számot tartani. Technikailag azt próbáljuk ki, most voltunk körülbelül 16-an, azt hiszem maximálisan online, és voltunk itt még kb. 20-an. Az a kérdés, hogy mi van akkor, hogyha 100-an vagyunk, mi van akkor, hogyha 500-an. És ezt így fokozatosan próbáljuk csinálni, hogy ne omoljon össze a rendszer, tudjuk közben tesztelni. Ha egy komoly Facebook hirdetés csak a magyar orvostársadalomnak kimegy, ez a Facebookon keresztül is legalább 50 000 embert elér, nagyságrendileg, orvostallgatóktól nyugdíjas kollégákon át. Ha ezeknek az 1%-a érdeklődik, szerintem óriási érdeklődésre lesz, vagy tarthatunk számot. És azt gondolom, hogy az HMAA-nek egy nagyon-nagyon komoly feladatot és küldetést tudunk adni, és megpróbáljuk azt a problémát, hogy nem tudunk Amerikában összegyűlni. Most indulnánk körülbelül ezekben a napokban az éves szaraszotai meetingre, ezt megpróbáljuk egy lehetőséggé konvertálni, hogy sokkal szélesebb társasághoz tudjunk szólni. De át is adom Ákosnak a szót, és nagyon köszönöm mindenkinek a segítségét, hogy ilyen hirtelen rendelkezésünkre állt, és ezt megszerveztük.
Igen, nagyon szépen köszönöm még egyszer az előadóknak és résztvevőknek. Azt hiszem az volt a legfontosabb, hogy gyorsan csináljuk meg ezt az elsőt, és akkor innentől kezdve már tudunk építkezni, és ez sikerült szerencsére, és nagyszerű 2 előadást hallottunk, és az HMAA is egyébként föltettük egyetemi honlapokra is, tehát szép lassan hozzá kell szoktatni majd a hallgatóságot, hogy ezek lesznek, és akkor nagyobb hírverést adunk neki, és akkor még izgalmasabb lesz. És még egyszer köszönöm akkor Csiba professzor úrnak is, hogy levezette ezt a előadást, és a
Lacinak hívnak.
Bocsánat, Laci, de azért a hallgatóság azért csak, mint professzor ismer.
Hadd tegyek már egy konkrét javaslatot. Ez nagyon jó volt szakemberek számára, ugyan ezt a szereket mi már azért ilyen jóváhagyási szinten is ismerjük előnyeit, hátrányait, de a népszerűsítése nagyon fontos. Viszont jó lenne olyan típusú előadásokat, pláne ha majd 100-ak fogják hallgatni, amiben megint visszatérünk az ilyen gyakori problémákra, mint fejfájás, hiszen a diagnosztikája, a szeparációja az alapvető fontosságú, és nem is feltétlenül műszerhez kötött, hogy egy kicsit népszerűsítsük, és a házi orvosok, egyebek, szakemberek között is felhívjuk azokra az egyszerű trükkökre a figyelmet, amivel szét lehet szeparálni ezt a dzsungelt. Ez az egyik. A másik, hogy amikor keverünk, én szerintem keverni kellene a kifejezetten szakembereknek és a érdeklődő, mondjuk egyetemet, középiskolát végzettek számára olyan kérdéseket is, mondok egy példával, olyan betegségek, amelyek a vezetési, tehát a jogosítvány korlátozásával járhatnak, demenciák, epilepsziák, alvási apnoék, és még lehetne sorolni sok minden, pszichiátriai problémák. Tehát ezek, amelyek nagyon sok embert érinthetnek, illetve nekünk is szakmai szempontból érdekesek, meg fontosak, és minden nap találkozunk velük.
Borzasztó fontos a kommented, és nagyon-nagyon szeretnélek kérni, hogy ebben tevőlegesen vegyél részt. Szívemből szóltál. Ez lenne az irány.
Na most, mint észrevettétek, az én stílusom egy populista irányba megy, mert gyakran a hallgatóknak, háziorvosoknak, meg néha laikusoknak is adok elő erről a témáról. De az enyémet könnyű elvinni.
Feljelentünk Vera Jourovánál, hogy mit populistázol itt. Mondd.
Ja, tehát igen, az én témámat azt jól el lehet adni, tehát az átlag hallgatóságnak, tehát nincs telezsúfolva a diagramokkal, tehát, ja.
Az az elképzelésünk, hogy a program összeállítását akkor ebben a szűk körben folytatnánk, tehát Laci, mindenképpen nagyon számítunk rád, Gönci Ágira, és hát a Laci, mármint Mechler Laci lesz aztán, aki az amerikai oldalt szervezi és meghívja, úgyhogy csak azért ilyen szűkebb körben, hogy ez menedzseltő legyen maga a program összeállítás, és mindenki, bocsánat, Berecki Dani, és azt gondolom, hogy ebben a körben kellene a témákat jelen pillanatban így látom kijelölni, az előadókat Magyarországról és Amerikából, és szerintem sikerre vagyunk ítélve.
Annyit hagyd tegyek már még hozzá, Ricsi. Én most egy szép profilt láttam, egy fénymásolót, meg a Mindot, vagy a képemen, de gondolom hallasz engem, hogy meg lehetne kérdezni az itt ülőket.
Ha arrébb mész, figyelj, fönt engem is látsz egyébként, van itt egy csoportkép is, ha arrébb klikkelsz, látod ezt a kis összejövetelt is, akik itt vagyunk mindannyian.
Most már látom. Hogy meg kéne kérdezni, hogy akár interneten, akár e-mailben, akár chatten, akár messengeren, tök mindegy, ők is adjanak javaslatot, mert egyikünk sincs a bölcsek kövének a birtokába, úgyhogy én örülnék neki, hogyha írnátok ti is, akik ott ültök a háttérben. Ugye mindenki maszkban van, nem ismerek meg így senkit, csak Ákos sejtem itt a jobb első sorban. Hogy ha kérdezzünk már meg másokat is, ne csak Szia, Ági!
Persze. Én csak azt akartam mondani, hogy a program összeállítását egymás között koordináljuk. Ezt kifejezetten úgy gondolnánk, hogy mindenki a saját köreiben gyűjtsön információt, és ami így vagy központilag hozzánk beérkezik Ágihoz, vagy külön hozzátok, hívj meg hallgatókat, és az ő reflexiójukat is be fogjuk építeni. Tényleg az az elképzelésünk, hogy ez a következő 20 évre 2 hetente egy érdekes program. Onnan jött az ötlet egyébként, itt vagy még Lóránd, lehet, hogy már ő elment. Lórándot én Angliában ismertem meg, az Institute of Neurology Queen Square nevű intézményben. Én ott voltam, mint nem a Queen Square-ben, hanem a University of Londonban jártam 5 évre, és a neurológiát ott hallgattuk, és volt minden pénteken egy Grand Round. Kicsit később kezdődött, olyan 3 órakor kezdődött, és oda mindig elmentünk, mert eszméletlen érdekes eseteket hoztak elő. Mindig volt esetprezentáció, és konkrétan beteget, nyilván videón nem csak személyesen mutattak be, és ott a szünetben találkoztunk magyarokkal, 2 magyar srác, és az egyik magyar srác volt a Lóránd, ez 1994-ben volt, azóta vagyunk jó barátok. Tehát ez hosszú idő. Tehát úgy képzelem, hogy ez valami ilyesmi lesz, egy ilyen Grand Round-szerű dolog lesz, nagyon is életközeli, és kinyitjuk, amennyire csak az internetet.
Hát köszönöm szépen, gyerekek, valaki még valamit akar mondani, vagy nem? Ági?
Nagyon szépen köszönöm, hogy ezt a gyors határidőt vettétek mindannyian, és azt gondolom, hogy a következő hetekben pedig összeülünk és összegyűjtjük a különféle csatornából érkező kéréseket, információkat, és formába öntjük, és egy ilyen időzítést és tervezést adunk az egész történetnek. Nagyon sok izgalmas téma van. Tehát eszembe jutott sok minden, miközben ezen gondolkoztam. A neuropatológia például, ami ugye sokszor egy kicsit háttérbe szorulhat, de a stroke...
Szívem csütke, úgyhogy te...
neuropatológia, és így tovább. Tehát vannak ötleteink, és akkor kitaláljuk ennek a koreográfiáját. Természetesen Messler Laci lesz az, aki az amerikai oldalt ezt hozzáteszi, illetve ötleteket.
Demencia.
Demencia. Ez a következő. A november 6-ai program lenne a demencia, ahol a Kovács Tiborra számítunk magyar részről, de még ezt is pontosítani, és megbeszéljük, hogy az amerikai részről ki legyen.
Akkor az a kérdésem a háttérben ülőkhöz, akik ott ülnek Ricsi mögött, meg Ági mögött, hogy ha muszáj választani a betegen, vagy muszáj lenne választanod a demencia és a Parkinson között, melyiket választod? Ha muszáj lenne. Na mondjuk a hölgy, aki itt ül, maszkkal, fekete, harisnya, fekete, így úgyse szoktak válaszolni. Csak akkor, hogyha személyre szólal. Nem hallok. Ricsikém, tedd már a mikrofont oda.
A Parkinsont választanám.
Hát ez elég.
Én is, mert az még valamelyest közelebb van a bélflórához, mint az Alzheimer.
Így van.
Nem helyes a válasz egyik esetben se, tanult barátaim, mert sokkal jobb elfelejteni kifizetni a sört, mint kilötyögtetni.
Ja, jó, ez akkor jó befejezés volt. Jó.
Legyen ez a final word. Szavaztok, és Ricsi, már egy 10 perc múlva visszahívlak, jó? Mert a másik téma ügyével, jó?
Igen. Oké, rendben. Szia.